Okay, good evening, everybody. My name's Andy Thomas. I'm a paramedic by background, and I have quite a few different things I do at the moment in life in terms of a main job. Obviously, tonight I was originally doing this webinar as part of Medtree and with CPD Me, and I've just recently changed jobs. So I do a mixture of clinical practice, education, and various other involvement with other work streams locally and nationally. What I'm going to talk to you about tonight is air in the chest and what's the next evolution in patient care. This is going to be a discussion. It's going to be me ranting on probably a little bit, obviously because I can't see any of this at the moment, and then hopefully some questions at the end. I always say there's no right and wrong answer in life, and that's true of this again tonight. Hopefully you'll be able to hear me throughout the presentation. I did just have my internet did just drop out a second ago, but it's normally pretty good, and hopefully that will survive the night. Timing was quite interesting. I've done a couple of things. I like to tweet, and I'm a big believer in Twitter. So if you want to tweet me anything this evening, it's Andy Thomas 135 is my Twitter handle. I'm just making sure all my phones are on silent so the tweets don't come through. And also, if you want to use a hashtag for tonight, just use hashtag air in the chest. Feel free to tweet and question and pass the information on, because that's obviously, I'm a big form-med believer, and if we can get this information out there, then that's great. However, without further ado, I think it's about time I just crack on with the process of delivering this presentation. So let's get going. So the first thing I'm going to do is talk about the difference between a pneumothorax and a tension pneumothorax. And I appreciate many of you on the line. This will be a little bit teaching you to suck eggs, but often we get people from various backgrounds, so I think it's important to define the difference first of all. And you can see the explanations up on your screen, and I could read them out, but that would be a bit pointless. I like to think of it in a different way when we're talking about pneumothorax and tension pneumothorax. Pneumothorax, or simple spontaneous pneumothorax, get various different titles. And these would, sorry about that, my screen's just kicked out. I'll just bring that back up. The difference between the two is the pneumothorax is normally from a medical in nature. It normally comes on a lot slower, and pneumothoraxes often just need to be dealt with in a hospital setting. And the tension pneumothorax is often a progressive, sometimes rapid build-up of air, which enters the pleural cavity and is often a result of trauma of some kind. And it's the tension pneumothorax that, for me as a paramedic, often causes me a lot of problems and a lot of difficulties in the environment. I say often, it's a rare occurrence if we're all being honest. But often when we come across this, certainly in pre-hospital practice, then it's often maybe in a paramedic's career or a pre-hospital nurse or whoever it may be. You know, they won't see a lot of these. When it comes along, there'll be a lot of pressure on dealing with it. So we're going to chat around the different things. I've just put a little representative picture up there just to give a quick example of, obviously on the left you've got your lungs up, no problems, and then on the right you've just got the imitation that your lungs down, and obviously that's because the air is filled with, the chest is filled with air, and that would need addressing quite quickly, and basically it leaves quite a gaping space within the pleural cavity once this has occurred. I thought I'd just put a cross-sectional CT scan up there again in the lungs, so you can see on the left there the lungs fully inflated, and you've got you can see the bronchial tree and all that going up nicely on the left, and that's very different in comparison to the right-hand side where you can see the lungs down, and the big black area is effectively air within that cavity space, and this can often result from various injuries. So, how often do these things happen, and is it a real problem that we're dealing with in pre-hospital practice? I'm going to look at quickly spontaneous pneumothorax first, and then I'll talk about tension, and I've got some other slides, so don't jump and think some of them statistics are rubbish. So first of all, spontaneous pneumothorax, so these are often medical causes, affects about 7.5 per 100,000 of the population in the US, and 37 per 100,000 of the population in the UK. It's notable that it's significantly less in women. Interestingly, there's a huge difference between the US and UK when it comes to this data, and when you look at the references that are at the end, but the authors of this paper couldn't really define why that was, and there was no significant explanation to that, but it's just interesting that from a simple or spontaneous pneumothorax point of view, we get more of them per population in the UK than we do, for example, in another Western country in the US. Now, tension pneumothorax is interesting. How often does this occur? And I'm sure if you sit in the tea room or on a break, which we know is very rare these days, but if you were there talking to some colleagues, then I'm sure you hear the war stories about, well, when I dealt with tension pneumothorax, yeah, I've done a couple of them and stuff like this. Well, some of the data suggests that's not the case. From a London paper done with basics doctors a little while ago now, they estimated that 5.4% of their major trauma patients were suffering a tension pneumothorax. However, their way of getting down to this figure was that any time a needle decompression was done in the pre-hospital environment, that would count as a tension pneumothorax. And other studies are very suggestive that this rate is not suggested to be that high. I've listed a couple of studies there, just of different environments and different locations, where they should range from between 0.7% to 30%. So the point I'm making there is, looking at some of the available studies at the moment, we really have no idea how often this occurs, and there's such variation in the studies, I don't think we can accurately determine in trauma how often patients do suffer a tension pneumothorax. So that's when we turn to the TARN data. With the TARN data, obviously we're looking at frequencies of chest injuries within UK major trauma, and the TARN data between 2005 and September 2013 suggests that out of every major trauma patient, so somebody with an injury severity score of greater than 15, 1 in 250, so 0.4%, pretty low, will suffer from a tension pneumothorax. Given some statistics looking at how many major traumas we have in the UK, it's estimated around about 20,000 major trauma cases a year, which will roughly equate to approximately 80 cases a year within the whole UK in the environment prior to arrival at hospital that potentially will be suffering a tension pneumothorax. So that's pretty low, I would suggest. However, there's potentially more than that. This data may be, I'm not saying inaccurate because it's TARN data, but my previous job a few years ago as a research fellow, once you start hard trawling patients' notes, compare to databases, and certainly I've done this myself, you often see a big difference. So data is what it is, but hopefully this is, I think, probably the most accurate one we can get to, and as you can see there, it's from quite a significant number of trauma patients within that register. What are the clinical signs of a tension pneumothorax? And I just want you to take a few moments now to consider yourself what you think the clinical signs of. I'm hoping, and I may be wrong here, sometimes I'm a bit of a technophobe, but I did set up a poll before you logged on there to hopefully ask everyone a question and then give you a choice of 5 answers. And I'm more than happy if Andy Ormerod wants to jump in now and see if this is working, but there should be a poll potentially when you logged in. If it doesn't, I'll just move on, so don't worry. Which is going to ask you a question about clinical signs of a tension pneumothorax and ask you to choose one of the 5 answers. So if you just want to have a look at that now. Yeah, so I can see you all starting to view the poll now, so it's on there ready to go. So if you all click on your little boxes which says within your screen share and go to webinar panel, that should allow you to vote on the question I've posed. I'll just let that go for a few moments. Is that gone? I'm just going to launch that poll again. See what's... Yeah, so that's it. Yeah, so almost all these. Yeah, we're getting well done, guys. Everyone keep voting on that for me, please. So we're at 70% of you have voted. So over the last few, I'll give it a couple of minutes just so everyone can get into the vote there. It's the first time I've done the poll, so thank you very much for participating, and I'm glad to see it's working. I'm getting some interesting figures coming back this end. So we're at 80%. I'll just give it another sort of 30 seconds for the last few to try and figure out their screen, and if not, I'll just move on. So what I've asked, and whilst a few of you are asking, the question was, what are the 2 most consistent signs of a tension pneumothorax? And I give you basically, I give you 5 choices. So the most 2 consistent signs: low SpO2 and tracheal deviation, cyanosis and hyperresonance, chest pain and shortness of breath, tachycardia and ipsilateral decreased air entry, and tracheal deviation. So we've got about 84% voted yes. So at the moment, just to give you a rough breakdown, and this is coming up on percentages. So there's about the two big most answers that we've got at the moment, and oh no, yeah, everyone can see the results with me. So that's good. I'm a bit confused with the percentages here. So Andy, if you can make any more sense of that, would be useful. But so 40% have said tracheal deviation and hypertension, which is quite low. So you wouldn't often see that. The two highest numbers on there, although I'm sure you can all do the same maths as me, that adds up to well more than 100%, is chest pain and shortness of breath and low SpO2 and tracheal deviation. And now what I'm going to do is I'm going to bring some of the signs up on the screen in front of you. So this is what I'm going to bring up now is and I'll just share results just so everyone can see them if you want to see them, and then I'll just hide them again actually. So clinical signs. This is from a paper which has looked extensively at the presentation of pneumothoraxes and tension pneumothorax and done quite a large data collection where they looked at the most common signs of a tension pneumothorax or a simple pneumothorax. And so the first one we get is chest pain, which is a universal finding. So chest pain should present in every patient who has a tension pneumothorax. This was a consistent finding in all cases, which is quite useful to know. So we're going to get chest pain. And then the second universal finding is shortness of breath. So if we think about a lot of the call-outs we get a lot of call-outs to chest pain and shortness of breath, and these are the two universal findings. These are basically what we're going to see in every patient who is suffering from a pre-hospital emergency or a tension pneumothorax is chest pain and shortness of breath, which in symptoms on their own would not obviously diagnose a tension pneumothorax. Then it would be a tachycardia, which it presents in 50 to 75% of the cases. Ipsilateral decreased air entry, so decreased air entry on the affected side. Again, a common finding. So once we start building the picture together, this would assist with you. So chest pain, short of breath, tachycardia, and as I say, reduced air entry on that side. Then moving down, but less frequent, is be the low SpO2. At this point, when we start talking about these signs and symptoms now, we get quite into the realms of that these are quite low signs and symptoms, so less than 25% low SpO2. And I remember when I first read this paper, it was a low SpO2, and I thought, oh, I'd expected to see that more. Hypertension, again, an inconsistent finding, in less than 25% of the patients will it affect the blood pressure. And when you think how a tension pneumothorax works and the pressure that causes, you know, again, we probably expect to see that more often. Tracheal deviation. Now, again, I'd like to think most people, it's often the one that I remember, certainly many years ago in training, when I was, you know, less educated than I am now, and that was what I was told. Oh, if you're going to go tension pneumothorax, there'll be reduced air entry, there'll be drum-like sounds, and the trachea will be deviated. That's what I got told. And again, so far out of those three I've told you, there's only tracheal deviation come up, and that's in less than 25% of cases. Hyperresonance is a rare finding, so the classic drum sound people expect is less than 10% of the cases. Hyperexpansion, so a slight inflation on the affected side, again less than 10%. And cyanosis, again being quite a rare finding. So when we look at those clinical signs, I think it's quite useful to see that, you know, almost it can be tricky to pull them out. And if you just get them universal findings on their own, then you know you could be multiple diagnoses there. So when you're assessing a patient in future, if you get, you know, hyperresonance, for example, but none of the others are presenting, then obviously I think, you know, there may be other reasons or causes for that. And it just give you bear in mind. And I think if any of the screenshots today, I think this is an important one. What clinical signs will present and what percentage of cases, and I think this is something to take away. And certainly, if we tweet or pass on to our colleagues, is certainly worthy of note. Speaking of the old deviated trachea, we can't move on without obviously some kind of chest X-ray to show the deviated trachea. Now, I've never seen one in my clinical practice. Obviously my background, I've spent 18 years in the Air Force and I've done multiple deployments to places like Afghanistan on the MERT and things like that. And even in that environment, where we saw significant more chest injuries, significant more amount of tensions and things like that, did I ever see anything that looked like a tracheal deviation presenting in a patient. And I'm sure if this patient had one like demonstrated in the X-ray there, then they'd be pretty end of life at this stage. We've talked about those clinical signs. We've talked about, you know, this X-ray here, but I'm going to bring the next slide up, which is just going to show a gentleman just on a repeat loop, just to give you the impression of what it can look like when somebody presents with that difficult breathing and have the issues around that. So as you can see now in the video, this guy's puffing away quite nicely. And if you can see on the screen here where my mouse is now, I'm just going to loop that round. So he's got a cannula in there at the moment. I'll be honest, that cannula looks very medial just from looking at that, and it doesn't seem to be helping this chap at all. There may be other injuries at play here. I don't know the specific case series, but I think it gives you a good idea of, you know, somebody in respiratory distress, somebody, if their background suggests that they've got trauma to the chest, that would give you consideration. So, what's the current practice? What's the current thoughts on this? What are people doing about pre-hospital tension pneumothorax, and what should we do as clinicians and practitioners? Now, we could be nice about this, and I don't mean let's all shake each other's hands, smile like over-friendly people in the picture that I've just pulled off the internet randomly. We're talking about the NICE guidelines for trauma management that have obviously released in February this year. The draft consultation was out last year, but there's been some tweaks, changes to it since then. And we're going to have a little look about what NICE are recommending at the moment. And is there any real sea change in management and assessment of tension pneumothoraxes, or is there any real treatment changes? So I've pulled these direct off the document. I didn't want to paraphrase them, I didn't want to misinterpret them, and then I'll discuss around them. So use clinical assessment to diagnose pneumothorax for the purpose of triage and intervention. So it's still saying primary focus is based on clinical assessment to see what's going on with this patient. It is talking about ultrasound and EFAS scanning now, extended focus assessment with sonography for trauma. So as some of you in your clinical practices may be carrying pre-hospital ultrasounders, the device comes pretty small now, certainly within my clinical practice here up in the northeast on Carew, we're carrying ultrasound. And this can be quickly and effectively used to look at the chest to see whether the lungs up, etc. And this should augment clinical assessment if you're trained and able to do so. What I think the NICE guidelines talk about, not in the summary, but when you start reading into the document a bit deeper, which is about 330 pages long if you've got the time, is they talk about this shouldn't be delaying time on scene. The evidence behind whether it works or not is not entirely strong, one way or the other, and therefore it raises some concerns that it shouldn't delay treatment on scene, it shouldn't delay transport to hospital, and a negative fast test, so a person who's not shown as having a pneumothorax or a tension pneumothorax on fast does not necessarily mean they're not suffering from that condition. So the jury's out a little bit from an evidence point of view. I have to say it's quite a useful tool, and I don't feel it delays on-scene times personally. And I think in pre-hospital and paramedic practice, and when I say pre-hospital, I mean any providers or paramedics as well. I think in specialist teams, in maybe advanced practitioners, your APs, your advanced practices, paramedics, your advanced nurses, your doctors that are out there, in trained hands, this can be quite a useful adjunct that will be done on the move as well. What it does go to say is only perform the chest decompression if the patient with suspected tension pneumothorax has hemodynamic instability or is severe respiratory compromise. So I'm sure we've all been there where we're assessing people's chests and we think, oh, that lung might be down a bit and stuff like that, but they're relatively stable with it. If the patient's stable and you're suspecting from trauma or for a medical reason that they've got some kind of pneumothorax, as long as that patient's stable and not compromised, then absolutely there's no need in the pre-hospital environment to be doing chest decompressions, and I think NICE has supported that, and I think that's very reasonable. For those things that can wait, hospital is definitely the best environment for that. What they are recommending is the use of an open thoracostomy instead of a needle decompression if the expertise is available, followed by a chest drain for those patients who are breathing spontaneously. Now, the misinterpretation I think we've had with these guidelines early doors is I've seen some big bold things out there on social media, knife not needle, and the infographics and all the pretty pictures to go with it. That's not entirely what they're saying, because there's a couple of issues around that. First of all, you need to be trained to do finger thoracostomy or open thoracostomy. If your patient is conscious, then to do this, if you weren't able to then put immediately a chest drain in, you would have to RSI the patient, get positive pressure ventilation, and then do it. And this is maybe not available to everybody. If you are truly presented with an unstable tension pneumothorax of a patient who is clinically deteriorated to the extent that you're thinking he needs intervention, looking at these guidelines and these recommendations, then that patient's treatment needs to be pretty sharp. And therefore, when you read into it, it says, in the ideal world, finger thoracostomies with positive pressure ventilation or with a chest drain is the gold standard they're recommending. However, if not available in the patient's condition warrants it, then needle decompression. And I think the thing with needle decompression, that will apply to most pre-hospital practitioners. Needle decompression is generally within most people's training who are practicing out there, and therefore it's likely the first intervention. Within that as well, there'll be maybe many reasons why other things can't be performed. Patients trapped in a car, can't get positive pressure ventilation, etc. Once you've decompressed the chest, if you get to the stage where this was necessary, then obviously you must continuously observe the patient for reoccurrence of a tension. And this guide comes very much out, and we're going to talk on it in a second, it comes very much out of a lot of what we do at the moment just doesn't work, or the patient retentions, and I can certainly speak from experience of picking soldiers up who were injured on the battlefield, and they would come on with sometimes 2, 3, and I even saw 4 brown or orange cannulas in, where whoever's been treating them have either had not success or it's worked for a short time. They've had a needle decompression chest, and that's something we're going to look at a little bit more in a second. But so the nice guidelines are out there, guys. I think it's NG39 off the top of my head, but the reference is at the end, and there's a link. But worth a little read. There's a summary guidance with the stuff I put up in front of you, and then if you're really into the sort of literature side of things, then you can read the main document. It goes into a little bit more depth of why they came to their decisions. So, finger first is definitely what we're saying. I'm not here to profess to you that finger is not the way to deal with this. In an ideal world, everyone would be trained to treat every trauma patient to a high level of care at the same level, but there's just not enough trauma patients to go around, and therefore we're never going to get everybody who responds to this level. And therefore, if not available, we may have to look at other things. And as I want to re-emphasise, even with the specialist teams there, if a patient's trapped in a car, and therefore, you wouldn't be RSIing that patient with 360 access, or you wouldn't be able to get a tube down in a traumatic cardiac arrest, then your needle decompression may be your only option. You must have positive pressure ventilation. I can't stress that enough. And the guidelines back this up. If you just cut a hole in the patient's chest and you've not got positive pressure ventilation and you don't put a chest tube in there, then you've basically created an open pneumothorax, and by creating that, that's probably not ideal for the patient. And obviously there's many of us out there that would potentially won't be trained to do RSI or finger thoracostomies within their normal scope of practice. So I think finger first definitely, but let's be honest and realistic, it's not always going to work. So, and then we're going to have to talk about size. So, does size really matter? Is the question we're asking. Does size make a difference? And what I mean by size is the size of the device or the equipment we're going to use to needle decompress that patient's chest. We've ruled out, we know finger thoracostomy is the gold standard, but if we're getting to the stage where to treat the chest, is what we're doing now with cannulas, etc., really going to work? And I'm thinking not. So does size matter, and is it important? First thing I'd say is size is important. And you'll have to bear with me on this. Hopefully no inappropriate comments coming in. Yeah, size is important, because if you don't have the right size needle, or you don't have the needle capable of penetrating the chest, then the procedure won't work in the first place, and then there's other factors that may affect it. So yeah, size is important. You do need length and girth, and again, I'm not trying to be funny with that comment, but you need good length and a good diameter, because if you're going to get in there, then we need to make sure it works. We need this so we can ensure effective penetration, so that we can remove the air from the patient's chest. And I hope that might sound catchy and a way to think, but length and girth is important. We've got to get through there. And what I mean by that is if you look at the dictionary term of girth, it is diameter, and we need a good diameter on these needles. We talk about, we've seen multiple cannulas before, and this may be because they don't long enough to penetrate the chest, or if they do penetrate the chest, because they're so narrow, they're getting blocked really quickly. Our fundamental aim is to remove the chest out of the air. I'll say that again, the air out of the chest, to improve the patient's condition. And our patient population is varied these days. We go from Mrs. Goggins, who's very thin, to a larger population, or in a Star Wars terms, we go from somebody like Princess Leia to maybe somebody like Jabba the Hutt. And that, again, I'm not trying to be derogatory in that term, but what I'm trying to emphasize is that we have a very, very different patient population now. And in trauma, we'd all like our patients to be a certain size, you know, your average size, but we're going to get really thin people that are difficult to manage, and we're going to get either very muscly people or very obese people. And we need a needle and a device, needle length, that will match these. And there's a needle up in front of you there, which is 10 centimeters long. And we'll come on and chat about that a little bit more in a while. But we do need to address the patient population, which for our practice now in this day and age is very variant. Obviously, people weightlift and stuff like this is just an example of a chap who before has had some pectoral implants done. And again, if you look where they are, yes, they might make him look, you know, all packed up in his t-shirt there, but that. Well, the needle's got to go through that. Will the needle penetrate that? What effect will that have on a needle? And again, we've got to think about this. So why do we need to go for a larger needle? Because the 10 centimeter needle I've shown up before, it would fit when I show people, or I've shown people that in training in clinical environments, people go, oh my God, we wouldn't put that in anybody. So let's talk about some of the evidence. The most commonly used sizes for needle thoracostomy are a 14 or 16 gauge cannula, and these lengths range from 3.2 to 4.4 centimeters. First of all, the old style cannulas we used to use 5, 6, 7 years ago with no safety features were about 4.5 centimeters in length. If you compare this to some of the cannulas we use now, then they've gone a lot smaller in their length. So again, it's going to make it even more difficult to penetrate them. And in multiple papers, these are associated, standard cannulation, with 50 to 65% failure rates. Due to not even penetrating the patient's chest. Even if you use a 5 centimeter needle, so we're saying, well, even bigger than the standard cannula we've got now, based on CT imagery of chests, this would still fail in 42.5% of cases to penetrate the chest wall. So therefore, we do need a bigger needle that's fit for purpose. I've just added this last other reference in at the end. The minimum recommended length for 90% success rate is now 7 centimeters, and this was come from a publication released last month in J-Trauma, a very well-respected trauma journal. Again, this was based on a couple of thousand cases, 2,500 healthy volunteers that were getting their CT'd, getting their chest wall looked at for other reasons. And they said that's what you'd need to penetrate on the standard landmarks we're using at the moment. So I think the argument for using standard cannulation is gone. It's not fit for purpose. And I actually think when if you look at the evidence base that they use within the NICE guidelines, is their recommendations are based on finger first as well, quite rightly, because the kit we're using is wrong. What it hasn't is assessed any of the more modern solutions that have come out over the recent years that are still probably speaking in terms of its infancy, and there are devices available out there. This is one such device out there. Obviously, I'll declare a conflict of interest here. There are other devices available. I have no financial interest in stake in this product. However, I did used to work for the company until very recently who distributed it. I have done a lot of training with this product in both cadaver labs and education. And I have to say it is a pretty fit-for-purpose product that, with the correct training, will solve many of the problems I think we find with needle decompression. However, if you pick it out of the packet and have not been trained on it, you will set yourself up to fail potentially. And that's the ThoraQuick device. And if you want to talk about that, that's hashtag ThoraQuick as a I like my tweeting. So if you compare that to your standard size cannula, we can start seeing about some of the problems we have there. Its length is 10 centimeters as opposed to 3.2 centimeters, and its diameter is an 8 gauge cannula as opposed to a 14 gauge cannula. It's got flexiplastic, which allows it to to be flexible once it's in the lung, once the lung reinflates, and it's got the eyelets, as you can see, which allows air to escape and prevents blockages. It sticks to the patient's chest. It has a three-way valve in there, and therefore it prevents tension and reoccurring because it doesn't allow air in, it only allows air out. And the tip of the needle is an atraumatic needle, so it has a safety feature built into it as well. We're not talking about the training of this device tonight. If you want more information about the training, I can tell you how to get that at the end. But these devices available. There's also other devices on the market. Prometheus do the Pneumothorax, and there's some other devices out there. The Helis needle, ARS needle, but I would suggest they're quite inferior. And then there's the bigger hospital-based products, which I don't think are suitable for the pre-hospital care environment because they start coming into quite serious bits of kit then, and the price starts going above the £100 mark, which is just not affordable in our environment. So, is such a device as that big 10cm needle I've just shown you, is it safe? And that's what we want to know. Well, the answer is yes. So there has been a clinical studies taking place on this device, and although the patient numbers are small, and this was done in the Heartlands Hospital, and again, you've got some handouts tonight that you can download, and I've put this paper within the handouts. You can download it. It's an open access paper, and therefore I'm not breaching any copyright or anything like that by including that in the handouts. 19 patients recruited with no complications, and the person who'd had a brief training and was delivering this rated it as very good or excellent in 90% of the cases. So from a user point of view, they found it easy to use. That device, although we're talking about tension pneumothorax, can also be used to treat pleural effusions. It can be left in situ for several days. It's a multi-purpose device, but it's a device fit for purpose. What you wouldn't do is use that device to try and cannulate a vein or anything like that, because that's what it's not designed for. It's designed for sorting out chest emergencies, not for getting access to give fluids or drugs. So it was used for 12 pleural effusions as well. Therefore, it has a pre-hospital and hospital-based use. I think 6 of the cases were tension pneumothoraxes, which was good, and it worked effectively on presentation. It was used in simple pneumothorax in a more controlled fashion, and as I say, the pleural effusions. So it's been well tested from that point of view. And as I said before, if you're going to use a device such as this, then you wouldn't pick it up out the pack. You do need some level of training on it first, because there is subtleties that we won't be going into tonight that you need to look at. Is it recommended? Obviously, there's no point taking my word for it. Obviously, as I've already said, I did work with Medtree on this product, and therefore, you want to make your own independent assessment. If you look at the recent Faculty of Pre-Hospital Care consensus statement on management of life-threatening chest injuries, they vary slightly from the NICE guidelines. These came out in September last year. They've taken a slightly different approach, a stepwise approach, depending on levels of training, and they recommend using decompression. But they said because of the existing problems with cannulas, then that's why people are seeing poor success rates. The third paragraph down is a direct quote out of that consensus paper, which again, for your convenience, is within your notes of your handouts this evening. And as it says, it suggests that the Thor has had good early testing, encouraging results, and that these devices may be preferable to the standard cannulas. Interestingly, they talk about the standard 4.5 centimeter cannulas, but the next time you're on shift or you're with your cannulas, measure them, and I pretty much guarantee none of them are 4.5 centimeters in length. There's no difference in landmarking, so all you need is training on the device itself and not how to landmark it. Is such a device easy to treat? And this is from the UK Student Paramedic Conference at the NEC last year. I went along, took a couple of sheep along with me, not live ones, and just a couple of sheep chests. Sean and Sarah, they came along with me, and I trained about 100 students that day, including Martin Berry, the College of Paramedics Chief Executive. He came in for, obviously, bless him, he got a bit of one-on-one training, but he came in and practiced the device, and the overwhelming feedback, and these students were varying at different parts of their training, was that it is a safe and simple device to use. Students were coming in at 12 at a time in 15-minute sessions, so very quick in between their lectures and their presentations, and we had some pretty positive results. I've replicated this around the country, and I've also done some online training videos for this that will be getting released in the next few weeks, I believe, from the company themselves. So there's some options out there on the training of the device, but there are other devices out there, as I say, but it is a simple solution. And when I talk about the title of an evolution, the evolution's not just in equipment, but it's in mindset. And what I mean by mindset is we've got to stop using kit that's not designed to do the job. Otherwise, we quite rightly will see high failure rates that we have done, and therefore the only answer is to go on to more invasive procedures like finger thoracostomy, when realistically, with thousands and thousands and thousands of pre-hospital care providers in the country, we're not going to train everyone to do so. So why does it go wrong? Why, when we are conducting these things, do they go wrong? Fear. Can you imagine if you've been in the a paramedic or a pre-hospital care practitioner or a hospital-based practitioner for 15 years, you got trained 15 years ago, although you get your fire training every year, you probably don't get refresher training on some of the clinical aspects you need, and you come across a 24-year-old man who's got a tension pneumothorax, and you're going into that bag for the first time in 15 years. You're going to be pretty scared of that process, and fear often leads to errors and a culture where we might make mistakes. Training, as I've mentioned, we're not getting regularly refreshed on this. We did it in training, and when I speak to people, when I have been doing the training in this area, unless they've attended a course like ATLS or maybe a FEC course or many other courses, ATAC and other people like that, then they won't have necessarily been trained again. The equipment we're currently carrying in most trusts, I would suggest, is setting us up to fail. And landmarking. When I talk about landmark, I don't mean the landmarks that are suggested in the literature and the text are incorrect. I just mean people don't landmark very well. I've been in a lot of cadaver labs over the last 12 to 18 months, and when you first give any device to these and say, show me where the second intercostal space is, mid-clavicular line, a lot of people get it wrong. And I'll even go as far to say, I recently did a demonstration, in a cadaver lab, and as I was talking, I just loosely landmarked up. I got a bit cocky, and I put it in the wrong intercostal space, and I've been doing a lot of training on this, so it can happen. And therefore, if we're aware of it and we make more of an effort, then that may assist in us not getting that wrong. In an ideal world, we need to practice. Amateurs practice until they get it right. Professionals practice until they can't get it wrong. That's easy me saying that. So for your HEMS teams out there, your critical care cars, your advanced paramedics, they may have that factored into their daily routines or their work schedules, heart, for example, training days and stuff like that. However, for the vast majority of people out there, they're doing it on top of busy. We all know the ambulance and pre-hospital care response is under huge pressure, and therefore training to get it to that level is what we want, may not be necessarily what we get. I'm going to use a quick analogy on the training and stuff like that. Well, why does a nation with 4.5 million people win the Rugby World Cup consistently as New Zealand have? For those of you who are rugby fans in here, which I'm definitely one of them, and was heartbroken to see them get knocked out at the group stages, then you look at a team like this who are just absolutely bred through training, through determination, through a culture that I think very few who are not in that team will probably truly understand, that they become successful at what they do. What they didn't do to win the World Cup is they didn't just rock up in trainers with incorrect equipment, without any training beforehand, and win that World Cup. And to be successful, you need to train. I am going to just try and briefly close the presentation, and I'm just going to airplay something across to you on the screen. Just bear with me, they should pop up in 2 seconds. I'm stretching the boundaries of technology now. Okay, so what you'll see now is a friend of mine. I just brought it up there, so I'm playing this off my iPad now, and I'm just going to add some bits into this patient. I'll put his veins, his nerves, and his arteries. So when we're talking about the landmarks, I think commonly what happens is people, I'm going to highlight the angle of Louis, or here. So we're coming down, we're feeling the angle, which is effectively into the space that's highlighted here. Which, sorry, I'll just highlight the right thing, which would be your second rib, so that the bottom end of your angle Louis fits to the second rib, and you want to come down to then the third rib. Just going to move that out of the way, and that landmarks. You're going to go just over that third rib, mid-clavicular line. What tends to happen is people, I'm just going to bring something up from the side now, a pen, is people tend to go here. That's the common error people are making. People are going into that first intercostal space because they often come down from the clavicle, and that's what causes problems. It's easy if somebody's quite slight build, but people like myself, I'm not the thinnest fella in the world, and as I've talked about, mostly in the obese population, it's really hard to landmark. You've got to really press down, get your landmarks, really feel into that second space, and then move down and go over the third rib. The other highlight I'm going to bring up now, I just have to take the pen off so it lets me highlight again, is I'm going to highlight the clavicle. So the clavicle's coming up in green now, and when you look at that, mid-clavicular line, I'm going to bring my pen back up, and if I follow this along there and roughly go down like that, not the straightest line I've just drawn there, that's mid-clavicular line. The clavicle goes to the tip of the shoulders. What tends to do when people are landmarking as well, people come in very, obviously that's in the incorrect space, but here people tend to come very medial. We saw that in the video before, which causes problems, not causes problems of the lungs down necessarily, but we're getting to areas where we don't want it to be close to. So if in doubt when you're doing this, I would always suggest, if you're on the right-hand side of the nipple, and you're really on the right-hand side of the nipple, you're probably far too close to the midline, and think slightly more lateral, and you'll probably end up being, if you go slightly more lateral, you'll probably end up in about the right place. The other complications when we're bringing these patients up is, I'll just take the pen off, sorry, is once we start adding layers of muscles, and I'll just bring them around to the side now, we can see how this makes it more difficult. So we just start putting layers of muscles in, and as you can see, it suddenly builds up, and we'll pop some skin on, and then it becomes a lot more difficult to landmark, and that's in a fit and healthy bloke, you know what I mean? So it's not easy out there for us guys, so I think is my take-home message on that one. And I will just bring my other screen back up now, hopefully. Go back into play, and it should leave me where I left off. Yep, more or less, excellent. And that's what we're trying to aim for when we're correctly landmarking to not fail. A bit of a quote there, people like quotes and these things, is when I talked about why it went wrong, fear, training, landmarking, all these things are a combination of things, because when we actually do this, guys, it's a one-off, okay? The procedure, whether it be a decompression or a finger thoracostomy in the correct circumstances, they're actually quite simple procedures. The problem is we're just not exposed to them enough unless you're in the high-end environments. And even those high-end environments, if you think, I think between all the air ambulances, they do 12,000 call-outs a year. Say they're getting to the majority of the patients. That's probably, you know, when you talk about total trauma cases, 20,000. So there's 8,000 go to non-HEMS units at certain times of the day and stuff like that. We're talking 55 cases to share amongst them. You know, you might get the person that does 2 or 3, and then you might get those people even in those high-end environments that are not doing them that often. They'll obviously be doing finger thoracostomies more often as a precaution, but you know, so what's the average paramedic, who on average will see 0.8 trauma cases a year, so that's less than 1 serious trauma case a year, ISS 15 or over. You can see the challenges here, and therefore our experience must tell us that you know, as it says in the quote there, experience is not what happens to a man, it's what a man does with what happens to him, and women. That's not it's just a quote. What I'm trying to say there is, guys, if you ever come across this, then you've got to try and control your environment, control yourself, dig down into your training, remember your landmarks, and use the appropriate device that I've got you. If you haven't got the appropriate device, use what you want, what you've got, but bear in mind it might not penetrate, and if it does penetrate, it might reach tension very quickly because of kinking, etc. So what are we aiming to do? Well, what I'm going to some of you may have seen this video. It's widely available on the internet. This video is not the Thor, for example. It is from a thoracoscope. It was done in Ukraine by the guy who heads up, the medical director of the Ukrainian Civil Defense Force, I think it's called. I have emailed him several times to try and get more information on the exact nature of this video, because there's a few things don't quite fit in. But it just gives you an example of how a longer needle works. Now, I think the needle in this case is an ARS needle. However, this patient has clearly been positively pressure ventilated. There's a thoracoscope in place, and I'm not sure, because it's very much zoomed in, whether there's any other treatments going on that we can't see, because this lung does inflate pretty quickly through a 14-gauge ARS needle, which, to be honest, I'm not sure it would go that quickly, and I think you'd need a wider gauge. However, we'll see, and I'll just play it for you now. So you see the needle come in. Actually, this needle comes quite a long way in. That's quite unnecessary. So if the lung was up and there's no safety features to the end of this needle, so no atraumatic needle, that would cause damage potentially. And you certainly don't need to come in that far. Again, with the other devices available on the market, certainly the main 2 that I've mentioned, they have safety features in that either click in or you feel the atraumatic needle pop out in your hand. but this comes up in about 4 or 5 breaths, so about 15 to 20 seconds, and the lungs fully inflated. If you ever look at an ARS needle, which I've been told this is, and when you look at the kit list on the Ukrainian Defence Forces website, it would suggest they all carry ARS needles. There's no way it's that big in terms of its size. Obviously, this looks quite zoomed in, so that might be what the reason behind that is. So that's our fundamental aim, is to get the air out of the chest. Again, I'm going to go back to the title. What's the next evolution in patient care? The next evolution in patient care is, I think, doing, when the experts are there, you know, using finger thoracostomy, but when the experts aren't there, and the vast majority of us are there, and this comes across us, then we need to take action. We need to do what we've been doing. We need to use our existing landmarks and make sure we get the landmarks correctly, but we need to use a device that works and is fit for purpose, and that's not a cannula, guys. So whichever one, you know, if you were deciding to change your practice, or you're an influencer and you trust, or you want to bang the drum of a different piece of kit, you have a look at them, you choose what you want to use yourself. However, we do need to use something different to help these patients who, when this happens for real, so let's be honest, we're going to have 2 patients, those with simple pneumothorax we can leave, those with tension pneumothorax, some of them with tensions may be stable enough to just get into hospital, but those who need it there and then need it correctly. And that's the end of the presentation. And I'll take questions in a second from Andy Ormerod, and I will just, the references will be available as well on there, excuse me, on there, and I'll just close my screen down and let Andy take control of the screen back to him, and then I'll answer the questions. Thank you, Andy.
Very much, Andy Thomas. Fantastic presentation there, Andy. Lots and lots of questions. I will just quickly flick back over to my screen. We've got quite a few questions. First one is from Rod. What about raised neck veins as an indication for a tension pneumothorax?
Yeah, interesting question there. Raised neck veins, the clinical theory behind that is, as the tension pneumothorax develops, there's pressure on the aorta, therefore you'll get that bulging in the neck. The problem with trauma patients is there's just not one thing wrong with them. So they're probably hemodynamically unstable, and in the experience of, and I can only talk about military trauma patients now. I've rarely seen this in a civilian trauma patient. You don't see that at all, and it wasn't anything that was mentioned in the literature within that document, which looked at a lot of other literature. So again, I think it looks good in the textbook, probably just like the tracheal deviation does, but whether you'll see that realistically, no, I don't think you will, Rob. So yeah, good question. But yeah, from my experience now, I'm not convinced that's a sign you're going to see.
Okay, I think that's answered the question. Next question is, are these used in the UK? I think Ben is referring to the Thoraquick.
Yeah, I'm just laughing at that because I can see that question. Then he goes, and then the next question from the same person, Ben, says, "I'm on that photo." So I don't know what photo that is, but maybe you can question and tell us, Ben, please. Yes, they are in use in the UK. I certainly carry them in our critical care scheme. They're used in some hospitals. It's not in widespread use at the moment. There's a lot of places trialing them, so CCAM, and I don't know if there's any of my critical care paramedic colleagues on from CCAM tonight. They're doing a trial at the moment. I no way want to come ahead of their trial. I have spoken to some of their critical care paramedics, and they're trialing Thoraquick versus Pneumothorax, and they're seeing some. I get the impression they're seeing more success with Thoraquick, and the reason potentially behind that is with Thoraquick you do a little pre-stab through the skin before inserting the device, because it's a much wider 8-gauge catheter going in there. If you don't do that, you can get a little bit of kinking. And the other manufacturer's device, their advice is to insert straight in, and I think that's affecting their success rates, and also securing the device afterwards is easier with the Thoraquick. So it is getting used. Other places it's getting used. It's getting very much used in Belgium, South Africa, and it's just getting launched in the United States within the last few weeks as well. And I was over in Las Vegas September last year with this device, and the American market had a lot of interest in this as well. So I think, yeah, I think it will grow in the UK, but like everything, these things take time. We're slow innovators in the United Kingdom compared to some other countries. We like to really take our time on products, and that's reasonable and fair. So yeah, it's some places are using it, but it's not in widespread ambulance use at the moment.
Okay, next question. Not relating to the presentation, it's almost like a sales pitch. What was the software program used to show the anatomy and landmarks?
Okay, yeah. I'll tell you. I was going to say I'll bring it back up on the screen, but you can't. Yeah, so it's if you go onto Apple, Google, not Google, yeah, Apple Store, it is Essential Anatomy 5. I think it costs $22.99. It's a little bit expensive. However, I have to say I use it in a lot of presentations, and it literally will. You press on it, you can zoom in and out, go inside the body, out of the body, and I definitely have no financial stake in this, but it's a really good app. And certainly from a lot of presentations I've done with student paramedics and others alike, they've then gone on to use this for their learning their A&P, and I'll be honest, I like flicking through it every now and then to learn my A&P, because like the rest of us, unless we're anatomists, we do forget the basics. It's more than we like to care to admit. So yeah, Essential Anatomy 5, and you can download it for about, I think it's about 22, 23 quid.
Okay, Andy, next question is, I'm a technician, and are there any techniques or are there anything that we can use to slow the development of a pneumothorax while waiting for a clinician who can decompress?
It is very difficult, I think, when you haven't got the ability to intervene. What I would say is do your basics well, Matt, is, assess the patient, allow the patient to take the most comfortable position for them. So there's no right or wrong. I know this sounds first aid, but I think the basics often make a difference. So if the patient will find the most comfortable position for them, they will lean. And if you try and force them into a position because you think injured side down is the best or whatever, then that'll just affect them. Let them go into the most comfortable position. Make sure you've applied oxygen. And if they've got any open chest wounds and they look like, they probably won't then have attention pneumothorax, but, make sure you address those, so maybe with seals and stuff. But yeah, basics done well, oxygen, reassurance, and what I would say for a technician sometimes, and I've certainly noticed this in my practice, if you're on your own out there on the road and you've got somebody with a tension pneumothorax and you're 5 minutes away from hospital and you're trying to get support and backup, that's 15 minutes away, take them to hospital. Because I think one thing we do now, we sometimes wait for the expert to come to us, where actually we could get the whole team of experts sometimes if we got them to a hospital quick enough. I'm not suggesting if Hems is 2 minutes away and the hospital's 15 minutes away, you scoop and run. That's not what I'm saying. But know your environment, know your distances, and do the basics well, Matt. And honestly, you can only do what you can do. Oxygen, basic care, and get them to the right place.
Okay, I think that's answered the question well. Next question is from Sophie. Would you decompress a child? And if so, would a standard cannula be suitable? And is there any difference in technique?
Well, I can actually speak from experience here, which is, I'm really saddened to say. I was quite involved in quite a lot of paediatric chest trauma, again, in my days on MERT in Afghanistan. And I certainly remember my first finger thoracostomy I ever performed was on a 7-year-old, and I nearly broke my little finger trying to get it in between the very tight ribs. We were using often on the peds, if we were using green cannulas, especially on the small kids. Again, in civilian practice, I've never seen it. Civilian trauma doesn't lend itself to this, but yeah, it's a good question. So yes, if I come across it and they clinically had a tension pneumothorax, yes, I'd do it. The Thor quick, in terms of its size and its diameter, may be a heavy-handed approach for a kid, depending on what age. So we're talking under 12s here, because above 12 they're pretty much an adult. So yeah, I might in those situations try a cannula. What I would say though is proceed with extreme caution, not with fear, but with caution. Remember, the proper devices, things like the Thoraquick, have an atraumatic needle on them. Your standard ones don't. So try and feel for when you come in. The top tip is attach your cannula to a syringe of some kind. Some people put water in them, but as you're advancing, just pull back the air on the syringe, because when you're in the chest wall, you won't be able to pull back. But as soon as you hit the pleural cavity, you'll hit air, you'll be able to pull back, and that will stop you over advancing. Because if you're getting it wrong, and you don't want to hit anything, you don't want to cause damage with a really sharp needle going into a little one. So yeah, just with caution. But if you're untreated, a child will die. Then I think make the best of the bad situation you're in at the time.
Yeah, well done there. Good question, Sophie. Next question is from Liz. What device are London Hems using?
I suspect London Hems are using positive pressure ventilation via an RSI and then using their fingers, to be honest. They'll do finger thoracostomies. Most air ambulances will do finger thoracostomies because they have the ability to put patients to sleep and then do the gold standard treatment. As in terms of what they're carrying in the bag as a backup, I have no idea. I don't work for London Hems. But if there's anybody on here who knows, please just type it in the question thing. But I don't know what they're using as a backup, to be honest, if anything, because they are a very high performing and skilled team, and I suspect rarely do they need to fall back on something else apart from off to sleep and a finger thoracostomy.
Okay, I think we've actually got somebody from London Hem speaking in a couple of months. I think we've got somebody lined up, so we might reserve that question. Next question from Robert is the costing issue that the NHS use cannulas instead of decompression kits, and that I would use in the military. So is there a difference between what the NHS use and what is used in the military in relation to costs?
So in the military at the moment, and I used to sit on the Tri-Service Equipment Committee until about 12 months ago, before I left the military. We had the ARS needle, which wasn't widely available in long parts of Afghanistan. Certainly most people came on around cannulas. So yeah, there's a cost involved in them. I think they're about, off the top of my head, about 14 quid. In the NHS, it varies from trust to trust, and there's no standard. Some might have needles, some might have bespoke. Very few trusts at the moment have got proper devices. Some of them are looking at them. I've certainly spoken to and trained and demoed, and I was certainly up in Scotland last week doing some training on this device because they had some interest in it. But yeah, no, cost-wise, the device, if you were to buy a single device for yourself, they're about 40 quid. Obviously, a big trust would, through the distributor, would get some kind of discount, I'm sure. But yeah, there's a cost involved. But ask yourself the other question. Yes, you can get a cannula for like 95 pence, but you probably have to put 3 or 4 in them, and then they probably won't even work anyway. And what's the health economic benefit of a young fit person dying from a tension pneumothorax and all the lost taxes and revenue and care that is attempted at saving his life when for a few extra quid you can get a device that will work. So yeah, I hope that answers your question, Robert. I'm assuming you're in the military from the phrase of that question, and if you are, yeah, I think at the moment the military have got ARS needles.
Okay, well answered. There is almost a double question here, one from Noah and Matthew, which I'll read out. Any advice on treatment if specific needles are unavailable and a normal cannula has failed and you're unable to do a finger thoracostomy?
Yeah, so look, it's a bit anecdotal, and the evidence behind it's actually not that strong now. But if you go and set an intercostal space and they've got big pecs, then try 4th or 5th intercostal space mid-axilla line. So theoretically the chest wall can be a little bit thinner there, but then that's not always the case. So try an alternative site. So those are your two sites. If they're really big and it's just not penetrating and that's all you've got, if you can't get experts to you, then give them a big injection of diesel and get that ambulance moving as quickly as you can, really, because you're going to run out of options there. You will know generally, even with the standard cannulas, if you penetrate, you will get a bit of a hiss. You do get a bit of a bubble, or you'll feel the air in the syringe. Where if you get no change when you first put that cannula in, it's probably not worked. So if you get no improvement in signs and symptoms on your monitor, then it probably hasn't worked, and that's a good telltale sign. So yeah, that's all I can really advise in that situation.
Matthew, to top that question up, it says, is there anything that you can do to increase the effectiveness of decompression if, for example, using a 14-gauge cannula, given its inappropriate length?
Again, I think try the alternative landmark if you get unsuccessful at the first one. If you are successful in penetrating, what I would say is, just be prepared to do another one. I would suggest the 14 gauge ones run out very quickly from my experience, and the patients start a retention quite quickly. Sub 10 minutes, I think, sometimes as well. Bear in mind, that's a tiny little cannula in a chest that's severely injured. There may be some blood in there as well, and that can clog up very quickly. As the lung comes back up, that might just fill it with a bit of gunk as well, as opposed to the devices that are bigger, wider board, and have eyelets in them. So yeah, I think just if that's all you've got, if it doesn't get through the chest wall and the alternative doesn't work, then I'm afraid, again, it's get hopefully help us around the corner, or you're moving to help, because there's nothing you can't make that needle longer.
Okay, and the last question from Mark is a spontaneous pneumothorax likely to tension?
Well, in effect, potentially yes. Anything can tension. it depends how the patient's compensating. You know, there's lots of different causes for spontaneous pneumothoraxes. What I would say is, if you've got somebody with spontaneous pneumothorax, these, like, you know what I mean, where they're pretty well. You listen to their chest and in the upper lobes, you can just tell it's not shifting air as much and stuff like that. But just monitor them closely, talk to the patient. If the patient shows any and develops any signs, keep an eye on them. But yeah, they can develop, but you don't need to be stood over them with a needle or anything like that. Because I have to say, the spontaneous ones tend to stabilise reasonably well, and then once they get to the hospital, they will decompress it, but under control. They'll measure how much air they're taking off. They'll do a primary X-ray first, and then repeat that. So yeah, just be wary of it, but don't be fearful of it again, because I don't think it's very common that they tension from medical causes that quickly if they're stable when you first get them. So just monitor.
Okay, last couple of short questions. Ben has asked, why is hyperresonance such an uncommon sign?
Good question, Ben. You know, the data doesn't give any reasons why that sign wasn't there. Just from clinical studies, it wasn't there. I think realistically, when these are really subtle assessments as well, we're talking about, in often difficult environments, and hearing that's slightly different and change. Now, I'll tell you what, I don't know why it's not there, but what I will say is look for abnormalities, look for differences. It might be a better thing. I remember when I was a technician, actually, and I was at a very serious RTC. And I remember listening to the patient's chest, and the firemen were cutting away in the background and everything like that. And I remember listening to the left-hand side of the chest. Sorry, the right-hand side of the chest first, then listen to the left-hand side of the chest. And it's just something sounded very different from one side to the other. And I couldn't figure out why, and I couldn't do anything about it anyway. I was a technician. And I remember that a basics doctor turned up just as we were extricating him. And I remember mentioning it to the basics doctor at the time, saying, look, something's weird, like, it just sounded different. So although hyperresonance might be, it's less than 10% of cases, it's all part of building that clinical picture. And if something just sounds different, so you tap on one side, which you don't think is injured, and the other one just doesn't quite sound the same, that for me, that's an indication something's going on there.
Okay, and the last question, Andy, is, do you have any tips on securing a cannula on the chest to stop it bending or occluding? And that's from Sophie.
Sophie, yeah, use a proper device. That's my tip. Get something like the Thor which has got built-in hub and sticks to the patient. It can be sutured to the patient for longer transfers or to be left in. The other things I've seen is people put them in and then put a little roll of tape over the top of them. People roll gauze either side of them. But to be honest, how effective is any of that? I'm not really convinced. What I would do personally, I would just, that's the only thing I had, I would leave it and just keep a close eye on it and handle with care. So not to dislodge it. That's the problem with a lot of the other devices, normal cannulas, and some of the other devices that are out there. They can be easily dislodged. You want something that sticks down or can be secured properly. But yeah, so the roll of tape over it, people put little gauze beside it. It may help you. It will occlude and bend in the chest as well if it's penetrated, or because it's only probably just penetrated by a fraction. It's very easy to clog that area up. So you can't do anything to that inside the chest. So yeah, hope that helps.
Well done, Andy. I think that's all the questions answered. If you have any more questions, as Andy said, he has popped up his YouTube address, and we will send you a follow-up email to make sure that all the questions are answered, and Andy might answer you personally by dropping you an email back. So just to let you know, from tonight's webinar, you will get an attendance certificate if you've been out through the duration, and you'll also get a link to the recording, and that will come within the next 24 hours via email, or indeed it will drop directly into your CPD portfolio. So if you're with CPD.me, your certificate and your recording will automatically drop into your portfolio. So all that you need to do is literally go into there and address what you learned from tonight's session. As Andy said, he has put some handouts on there. So if you're using a computer or a PC or Mac, on the right-hand side, there is 3 handouts, which we'll also put online. So where the link is to download the video or to watch the video, we'll also put the link to those 3 download documents. If you're on a mobile device, if you quickly touch the screen in the center, at the very bottom in the middle, you will see handouts. If you click on handouts, that will also give you the ability to download the handouts. So I'll tell you a little bit about some more webinars that are coming shortly. On the 29th, we have a webinar which I'm going to demonstrate how to use CPD.me to build and record and keep an accurate record of your CPD, including how the webinar certificates drop in automatically. On the same day at 8 o'clock, Andy Thomas and myself is going to go through the new Clinical Skills app and talk about some of the new features, and also give you guys and girls some opportunity to tell us what you want in the future updates to make it fit for practice. I am aware we had a couple of issues last week with some Samsung devices, but I think that's all sorted now. But if you do have any further issues, drop us an email, and either myself or Andy Thomas will quickly answer you and resolve the issue. Another quick webinar we have is on March the 16th on fitness to practice, and Oliver Munday will be telling you how you can prepare and ensure that you are always kept in a fit for practice status, certainly for those people registered with the HCPC or indeed the Nursing Midwifery Council. And then on March the 20th, we have got Dr. Mike Davis, who's going to talk to you about structuring a teaching event, and that might be a presentation or some kind of learning or development event that you're planning to host for the future. If you want to have a look at what webinars we've got listed, and we've got about 20 more planned for the next 5 or 6 months, have a look online at cpdme.com/webinar, and please do share these on social media because they're a complete free resource. You do not have to be a member of CPDME to access them. They're free for anybody to access. Because we want to get people out there understanding that you can vary your learning activities, and webinars, I believe, are a fantastic way for you to do that. All that's left for me to say is thank you very much for joining us on this fantastic Thursday evening. Thank you very much, Andy Thomas.
Yeah, no worries. Cheers, Andy. Much appreciated, mate.
And thank you very much indeed for everybody joining us tonight. And so, as I said, you'll get the recording and you'll get the certificate within 24 hours, and we'll also put links on there to the 3 handouts that Andy's kindly provided. Thank you very much, and have a good evening. Good night.